Let's see. Okay, it's on. All righty, so I'm going to talk to you today about hemochromatosis. Disclosures, I'm a member of the American Board of Internal Medicine Hematology Examination Committee. When I am required anytime I give a presentation to assure you that the presentation does not reflect any of the activities of the committee. Also, to remind you that because I am on that committee, this presentation cannot be recycled into a board review course. I was, until very recently, serving as a hematology safety consultant on a clinical trial that was jointly funded by the NIH and Sanofi. The topic is not related to my lecture topic, and in fact, the study went kaput before the first patient was enrolled, so my involvement consisted of filling out a bunch of forms indicating I didn't have conflicts and one-hour telephone call. I'm also the editor of a hematology textbook published by Lippincott, and although I don't write the hemochromatosis chapter in that particular textbook, it is in the section I edit. So we're going to begin with a patient that I saw recently. So this was a 21-year-old male who was seen by a physician in the community for erectile dysfunction, having been referred by his primary care provider. The student, again, is a 21-year-old male. He drinks a lot. He smokes cigarettes. He's on meds for ADHD and also for an affective disorder. His grandfather died from liver failure, and he has some relatives with diabetes. When he was seen at this physician's office, his CBC was normal, but he had some moderate abnormalities in his liver chemistries. His transaminases were both just a little bit above twice the upper limit of normal. The physician who saw him measured his testosterone, and the first time it was slightly low, and the rest of the time it was normal. But in any event, he was concerned, had some concern about other systemic diseases, and ordered iron testing. So the serum ferritin was 412. The upper limit of normal varies a lot depending on laboratories that are doing the tests, but usually the upper limit of normal for a male is somewhere in the 300 to 350 range, so this would be a little bit high pretty much any laboratory. Serum iron was quite high at 268. The total iron binding capacity was 323, which is solidly in the normal range, but the saturation of the total iron binding capacity was 83%. The transferrin was measured and was at the low end of normal at 231 with a saturation of 116%, and we will talk about that a little bit more later. When the physician received these results, he sent off genetic testing for the HFE, the hemochromatosis-related protein, and the patient came back as homozygous for the C282Y mutation. So the patient was then referred to me. So the patient comes to see me. I elicit the history that you have seen before. On physical examination, other than being kind of nervous, the main finding was that his liver edge was palpable and slightly tender. I did an ultrasound of his liver, which showed moderate hepatomegaly with some fatty infiltration. His spleen was normal sized, but towards the upper limit of the normal size. And his ferritin at this time, which was about a month later, was just a shade over 1,000. So at this point in the evaluation of the patient, what are we dealing with? We are dealing with a male who is homozygous for a common HFE mutation associated with iron overload. He has laboratory evidence suggestive of iron overload. Namely, he has a somewhat elevated ferritin, and he has an iron saturation of either transferrin or TIBC, which are well above the upper limit of normal. The upper limit of normal for either of those should be somewhere in the 40% range. You'd think about screening for hemochromatosis when you get somewhere above 50%. He has a family history of diseases like liver failure and diabetes, which are associated with iron overload and specifically with hemochromatosis. Of course, it's important to always put these things into perspective, that most people who had a grandfather who had liver failure don't have hemochromatosis, and most people who have cousins, uncles, aunts, etc., with diabetes don't have hemochromatosis either. The most common reason that you observe a family history of liver failure, for example, in a relative of a patient who drinks a lot, is that family member probably drank a lot too. And diabetes is sufficiently common that it doesn't necessarily mean that. But it is certainly suggestive. It fits in with the picture. He has some clinical findings which are potentially consistent with iron overload. He has erectile dysfunction, which is relatively common, although not so much when you're 21. It could be related to his medications. He is on psychoactive medications, which are associated with erectile dysfunction. It can be associated with his affective disorder as well, just outside of the medications. And it is something that one runs into in people who drink a lot. He's got a somewhat enlarged, somewhat fatty liver, and that could be related to his hemochromatosis. On the other hand, it could also be from the drinking. So the question is, at this point, what are we going to do with this patient? But we'll begin by reflecting on what exactly hemochromatosis is. Hemochromatosis refers to a collection of hereditary disorders of iron metabolism, which are associated with excess iron absorption and pathologic deposition of iron in tissues where it does not typically reside. So if you have an elevated ferritin, for example, and your iron is all staying in the reticuloendothelial system, so what? It's really not going to do you too much harm there. It is when it deposits in the liver particularly, but also in the pituitary, in various other, in the synovium producing arthritis, that you run into problems. Hemochromatosis is a disorder of iron absorption. So it is that your body does not how does your body regulate its iron level? It regulates it at the level of absorption. You do not have a controlled way of regulating your iron output, or you get excess. It isn't like when you drink too much water, you pee it on out. To balance it out, you don't have an equivalent thing that lets you pee out iron in a way related to your iron balance. You do lose iron every day. You lose it in the form of the minuscule amounts of iron present in sloughed skin and in sloughed colonic and intestinal epithelium. But and for women, iron is kept in iron balance and sometimes in iron imbalance by menses and by childbirth. Each child represents roughly 800 milligrams of mom's iron. But in any event, iron is regulated in a feedback way at the level of absorption. It is regulated by a peptide called hepcidin. What hepcidin, in the presence of hepcidin causes downregulation of a protein called ferroportin, which sits on the outside of most cells, particularly iron-containing cells, and is responsible for iron being ejected from those cells. In the presence of increased ferroportin, iron is retained in those cells. In the presence of decreased ferroportin, iron is absorbed and then sent out into the circulation from those cells. So the disorders of hemochromatosis are, for the most part, associated with impaired hepcidin production or with impaired hepcidin function. So one question that's a reasonable question to ask is, to diagnose hemochromatosis, why do we go through all this other stuff with genetic testing and such? Why don't we just measure hepcidin? And that's a good question, but when hepcidin is not readily available to measure, there's tests that have been validated for measuring it, but it doesn't. But unfortunately, they don't seem to be reliable or useful in the diagnosis of hemochromatosis, and that's something that has been demonstrated in some studies that haven't been published yet but have been presented at meetings, although some reduction in hepcidin message has certainly been shown. And this is kind of how hepcidin gets produced. So here's hepcidin down here, a little block, no color. And this is the stimulation of hepcidin. Bone morphogenetic protein 6 binds to these various signaling peptides. The hemojuvelin, transferrin receptor 2, and HFE form a complex in kind of the center of this process. And in the presence of an intact complex containing these intact proteins, the signaling goes to promote the production of hepcidin. In the absence of any of these proteins, or any one of these proteins, then you get a cutoff of hepcidin production, inappropriate production. Transferrin receptor 2 is distinct from transferrin receptor 1. Transferrin receptor 2 regulates iron metabolism at the cellular level, and it regulates erythropoiesis. Transferrin receptor 1 is a transporter. It's what carries transferrin-bound iron is how it floats in your circulation. The transferrin receptor is what brings the iron into the cell for transferrin receptor 1. Transferrin receptor 2 binds iron-carrying transferrin, but doesn't transport it into the cell. It just regulates these other processes of iron efflux from the cell. So, what are the types of hemochromatosis? Well, basically, if you look at it physiologically, there are 4 types of hemochromatosis generally. 3 of them are associated with decreased hepcidin production, demonstrated again at the messenger RNA level, a little harder to demonstrate at the protein level. And 1 type that's not associated with an abnormality in hepcidin production. Far and away the most common is what people like to refer to as classic hemochromatosis, which is due to mutations in the HFE protein. It is what is observed in something like 86% of cases of hemochromatosis in the United States. The mutations that are the most common are C282Y and H63D. When you order hemochromatosis genetic testing, you get that's what they test for. There are a couple of other mutations that are sometimes tested for. They are of significantly less clinical significance. It's autosomal recessive. The next most common type, which is infinitely less common, is juvenile hemochromatosis. And it is characterized by early onset of iron deposition, which is usually severe. So you will get when you are dealing with juvenile hemochromatosis, you get people who are in the situation where they have they're 18 years old and they're in heart failure because they've had massive iron deposition in their myocardium, that they have cirrhosis at the age of 16 or 17 because of the excessive iron deposition absorption. And it is the more common mutation that causes this is hemojuvelin, hence linked to juvenile hemochromatosis. However, there are some very rare cases that are reported with a mutation in the hepcidin gene itself. Then another rare type, somewhat more rare than juvenile hemochromatosis, again also autosomal recessive, is a mutation in transferrin receptor 2. It tends to have an earlier onset, but it is milder than juvenile hemochromatosis. So it's about halfway between type 1 HFE hemochromatosis and type 2 juvenile hemochromatosis. Then finally, there's the ones that are associated with normal hepcidin production, and these are what's called type 4, sometimes called ferroportin disease. Because what happens is you have an abnormality in ferroportin. Ferroportin is downgraded by hepcidin, and therefore the iron remains in the cells. If in the presence of, in the absence of, so in the absence of hepcidin, cells are pumping iron out into the circulation, like the epithelium is pumping iron out into the circulation, from whence it will then wind up in other cells. And so there's two types. This is more common than we think it is. You can test for it. It costs $1,500 and insurance won't pay for it, so usually we don't do it. And the reason that it's not all that significant is that it's generally not as bad a disease. 4A is associated with lack of ferroportin on the cells. And what you get there is you get iron sticking in the reticuloendothelial system. You have a high ferritin. Your saturation's generally not so high. And it's kind of it's just sort of an interesting thing. Doesn't give you much trouble. In type 4B, which is again less common, you get something that resembles actual hemochromatosis, but it's associated with, but it does tend to be a bit milder. Type 4A doesn't respond well to phlebotomy. People get anemic because, of course, the iron's just stuck in the reticuloendothelial system. Type 4B is a little less tolerant of phlebotomy than regular HFE hemochromatosis. So again, just reminding you, these are the proteins for the most part that are primary. HFE is the main one, hemojuvelin next most common, transferrin receptor 2 quite rare, hepcidin itself extremely rare. So these are the abnormalities that occur in hemochromatosis. How does hemochromatosis show up in your office and in your patients? The symptom. This is an older paper, but frankly, nothing as good or different has been written since. The most common finding in hemochromatosis is fatigue. Now you always hear about people with iron poor blood and all that, and so here's a person with like iron-rich blood. Why don't they feel good? Well, it's probably because of the deposition of iron in various organs, particularly endocrine organs, that are contributing to fatigue. So extreme fatigue is the single most common presenting symptom. Arthralgias is the next most common, both of them a little bit less than half. After that, and the characteristic finding of the sort of arthralgia arthritis is an X-ray pattern that looks a lot like pseudogout. Next up, about a quarter of patients show up with loss of libido or erectile dysfunction, again, typically related to reduced testosterone. The other feature that hemochromatosis is famous for is skin hyperpigmentation. Hemochromatosis is sometimes referred to as bronze diabetes. I've seen a lot of hemochromatosis. I have seen a lot of people with skin hyperpigmentation associated with hemochromatosis, and I really haven't seen too many that I would have thought were bronze, at least not from primary hemochromatosis. I have seen that occasionally in people who have secondary iron overload from, for example, excessive transfusion. But basically, what a person with severe skin hyperpigmentation from hemochromatosis looks like. And looking around the room, let's see, 1, 2, 3, 4, fifth row on the end. Hold up your arm, please, because your shirt is the color of a patient with skin hyperpigmentation due to hemochromatosis. They are typically kind of a light bluish, slate gray kind of color. So, we're using audience participation here. It's not quite as dark a blue as your scrubs, for those of you in them. But anyway, so they're just kind of blue. And they're gloomy too. But any event, other things, palpitations, again, almost as common, depression, fairly common, and abdominal pain, which is likely mostly related to liver abnormalities, is fairly common in people with hemochromatosis. So now, none of these things leap out to you and say iron overload. What did the doctor call it? Well, doctors typically call it things like arthritis because that is, what they present with. They may call it liver disease because liver abnormalities are fairly common. They might call it some kind of gastric disorder because what else gives you abdominal pain? Hormone deficiency, that's what this guy would have been labeled as if they had not repeated his testosterone levels. Psychiatric disorders, again, it's maybe related to some of the endocrine things, but that was another possibility for this patient. Iron deficiency. Well, you got something wrong with your iron and you're tired. Must be iron deficiency. That's a little hard for me to say. And of course, just plain old diabetes, because a significant number of these folks are diabetics. However, that accounts for 58% of doctors to whom patients with hemochromatosis presented categorized them as having one of these things and treated them for it for some time. However, something like 40% suspected early on that they might have hemochromatosis and referred them for testing. And what are the things you suspected on? You suspected on the constellation of symptoms and physical signs, which is what this patient's doctor did. You suspected on the basis of abnormal laboratory tests. A fair number of folks in the course of routine physicals get serum irons measured. I think it's a bad idea generally, but it's, because you really need to measure more stuff to really get anything useful. But if it comes back elevated, particularly in men, it's going to be, it requires further investigation. Some people may have a family history. Now, I have had a lot of people come to me and say, my father or my uncle or my brother has hemochromatosis, and I've had people come and I've had one person come and tell me that his father had hemochromatosis and he wanted to be tested, and I tested him, and apparently his mother had hemochromatosis too, and then his wife said she wanted to be tested, and I was thinking, this is not it's not a social disease. And darned if her parents hadn't both had hemochromatosis too. And so, it's like they wonder if they met in the waiting room or something like that. But they're magnetic. So, between the two of them, they were more like if you had a compass, it would point at them. But anyway, so family history does show up occasionally. But a key point to remember about hemochromatosis, and this is not a value, this is again from an older study, but it is not a value that has changed over the years. And of course, it's not the case in my patient. But the time between presenting with your first symptom that ultimately is attributable to hemochromatosis and a diagnosis, on average, is 10 years. So many people who are just being managed for diabetes, for example, may turn out to have hemochromatosis. It is one of the most common genetic diseases observed in white folks. So how do you look for the diagnosis? Well, should you do genetic testing? Well, the answer is genetic testing is useful under certain circumstances. First place, all you can really test for is HFE. The other mutations, which again are much less common, require some kind of a research test, basically. In juvenile hemochromatosis, which is the next most common variant, is largely diagnosed based on on history and constellation of symptoms. Somebody presenting with the first patient presents with heart failure and found to have iron overload, and the next patient in the family are the younger siblings that you start testing prospectively. So you do genetic testing in first-degree relatives of known HFE hemochromatosis patients. So, for example, my patient has a brother. The brother probably ought to be tested. You do it on the basis, as in this case, of abnormal iron studies. So the main way you detect it is through biochemical testing. What do you do for biochemical testing? You can look at the transferrin or total iron binding capacity saturation. Usually if it's greater than 45% in a woman or 50% in a man, you think of doing HFE testing to follow up on it. The other criteria for genetic testing on biochemical screening is a ferritin greater than 200 in a woman or greater than 300 in a man. So these are reasons why you would test it. Should we be screening everybody to see if they have hemochromatosis? There are a number of organizations of hemochromatosis patients that advocate that. But the U.S. Preventive Health Task Force has reviewed it several times and has not come to the conclusion because of the variable penetrance of hemochromatosis if you diagnose it, and the concern about whether you're actually going to need to do treatment, and there's a significant debate about that. Now, and part of the reason, of course, is that abnormal iron studies do not necessarily mean hemochromatosis. There are specific genetic issues that are associated with abnormal iron testing. For example, ferritins in the hemochromatosis range are seen in something like 7% of African Americans who are on subsequent genetic testing are not found to have any disorder of iron metabolism or hemochromatosis. The liver disease can produce elevated ferritin. Certainly inflammation can produce elevated ferritin. The iron saturation is typically not as high. It's typically either normal or just a little bit above normal, so it might be 35 or maybe 40 for that. What do you see it in? You can see it in alcohol abuse. You can see it in hepatitis C. There is something that is now called the dysmetabolic iron overload syndrome, which basically is fatty liver associated with an elevated ferritin. These patients typically have a fairly normal transferrin or TIBC saturation. Dr. Olive and I are following a lady who probably has this. And it's basically non-alcoholic liver disease, which has always been known to have an abnormal iron metabolism. And they just gave it a different name. And then you can have elevated ferritin just on the basis of inflammation or other significant underlying diseases. Back in the late 90s, when I was at another place, I went through all the patients in over a 1-year period who had a ferritin greater than 1,000. Very few of them had iron overload disorders. Most of them had some kind of significant illness that was definable, but was not necessarily iron metabolism related. Fair number of patients with liver disease, a fair number of patients with significant infections, a fair number of HIV patients with opportunistic infections have ferritins greater than 1,000. a ferritin, there were some papers in San Francisco around the year 2000, which argued that a ferritin greater than 10,000 in an HIV patient was diagnostic of histoplasmosis. We actually reviewed our database after that, and it was likely because they didn't see much histoplasmosis in San Francisco. Over in the Midwest, where we saw a lot of it, it was not certainly diagnostic. There are things called iron-loading anemias, and what these are anemias associated with ineffective erythropoiesis. So where there is a lot of erythroid activity in the marrow, those erythroid cells produce a molecule called erythroferrone, sometimes called ERFE, because that's what what erythroferrone is an abbreviation of something else, and ERFE is what the letters spell. But basically, erythroid cells produce this, and that's how red cells feed back to cut off iron production. So when you're iron deficient, you're not producing enough red cells. You aren't making the erythroferone. The hepcidin is unopposed, and you're getting more iron on board. But these people are suppressing hepcidin by the increased erythroferone, and increased iron is absorbed. It's confusing because a lot of these disorders are also transfused. But people with hemoglobinopathies like thalassemias and with myelodysplastic syndromes will frequently show laboratory signs of iron overload even before the first time you transfuse them, just because they have their large erythroid mass that is ineffective and doesn't actually make cells that circulate, suppresses hepcidin and leads to increased iron absorption. On the other hand, having abnormal genetics, like this person who is a homozygote for the C282Y mutation, doesn't necessarily mean you have iron. It means you have hemochromatosis. It doesn't necessarily mean you have iron overload. There is variable penetrance among patients with these mutations, so meaning that somebody with the same mutation doesn't necessarily have the same degree of iron overload. There are a lot of epiphenomenon that change that. For alcohol abuse is a confounding factor, which tends to lead to an increase in your iron overload. Women with particular hemochromatosis mutations are much less likely than men to actually have iron overload because of menses and childbirth. It is probably one of the reasons that hemochromatosis has become so common in the population, because you think at it sort of in an evolutionary standpoint. Once upon a time, women would have lots and lots of children. What's one of the big drawbacks of that is obviously lots and lots of children means you lose lots and lots of iron. If you are a person with hemochromatosis, you are absorbing a considerable amount of iron, and so you are better positioned to survive as a woman with hemochromatosis. And as a man with hemochromatosis, you mostly, looking again back, at the sort of pre-modern era, mostly by the time the diabetes and the arthritis started to get you, you were past your child-producing years anyway. So that's probably one of the reasons why it's such a common mutation. People with the C282Y mutation, which is what my guy has, are the ones who are more likely to have iron overload, but even with them, it's not 100%. If you are a homozygote for H63D, you have a very low likelihood of iron overload. You wouldn't routinely, for example, phlebotomize a person with H63D unless you actually found evidence of iron overload. If you are what's called a compound heterozygote, which means you've got one C82Y gene and one H63 gene, you may have iron overload, but it depends on confounding factors. So women who are compound heterozygotes hardly ever have iron overload, unless for whatever reason they maybe had a hysterectomy early in life and their menses stopped. Men may or may not. They typically do have some abnormalities in their irons, in their biochemical iron studies. Some of it depends on other things. If you're a compound heterozygote and you get hepatitis C, then you have a very high likelihood of developing iron overload. Also, if you drink heavily. And heterozygotes who only have one abnormal gene basically don't get iron overload, but they typically do have some mild abnormalities in their laboratory studies. So if you take a group of people who do not have an HFE mutation and a group of people who are heterozygotes, the ferritin and the saturations are different between the two groups, but they're not up in the hemochromatosis range. So what are you going to do? Who do you treat? You don't treat people just because they have hemochromatosis. You treat them because they have hemochromatosis with iron overload. In some of the other disorders associated with iron overload, because they are unable to mobilize their iron effectively in order to replete the red cells you remove, you may not actually treat them, you may just observe it. The treatment is basically phlebotomy. You should take 500 milliliters of blood, which is a unit of blood, a week, if possible, until the ferritin gets down somewhere towards the lower limit of normal. Most authorities that I like use a ferritin of 50 as your target. I have one person who is very elderly and very frail, and I use a ferritin as 100 in her case. She doesn't have much in the way of iron overload symptomatology, but she is very intolerant of phlebotomies. There are people who say that you should get the ferritin down to 0, but of course you do need some iron for some things, and that's probably a little bit too low. In some cases, like juvenile hemochromatosis, you actually phlebotomize patients twice a week until you get it down, because you're trying to get it down. Chelating agents like desferoxamine don't work very effectively in hemochromatosis. Same with XJ, deferriprone, the oral chelating agents. They don't work fast enough to get your iron overload down in hereditary hemochromatosis. And it is helpful to moderate alcohol, but it is important to understand that it may take years to deplete a patient's iron stores. Typically, you don't get symptomatic iron overload until your excess iron capacity is something like 10 grams. Now you've been absorbing, half a milligram or so every day as a person with hemochromatosis. And so it takes a while to build it up, and it takes a while to get it out. So you're 10 grams up by the time you are diagnosed. How long is it going to take you to get that out? Well, it's actually easy math. Each milliliter of red blood cells contains roughly a milligram of iron. So if your hematocrit is 40% and you're taking off 500 milliliters of blood, then you're taking off 200 milligrams of iron every time. So if you have 10 grams of iron overload at 200 milligrams, it's going to basically take you a year to deplete that iron. On the other hand, you are simultaneously absorbing iron as you go, so it may not be quite as fast. Second, your hematocrit may drop a little bit, and so you're not getting as much out. Hardly anyone actually is 100% compliant with it, so it takes a little longer. And many people may have 20, 30, 40 grams. So again, it can take years to deplete you. And it's helpful to moderate alcohol because that does increase iron absorption. So how well does phlebotomy work in hemochromatosis? Well, There are things it does not do. It does not eliminate diabetes. If you are a hemochromatosis patient and you've got diabetes from your hemochromatosis, phlebotomy will not help you. Same thing with cirrhosis. It probably does not help heart failure. So what is likely to get better? Fatigue is likely to improve. Your skin pigmentation problems will certainly improve. So, it is actually a remarkable thing when you have a person who comes in who's blue, and you phlebotomize them, and then a year or so down the line, they're kind of pink. Depression does get better, and the abdominal pain gets better. What is much less likely to improve are joint pains, which is a significant contribution. Erectile dysfunction doesn't generally get better. And palpitations, which most likely represent iron deposition in the heart, don't get better either. So let's get back to my patient. So again, the genetics are consistent with an iron overload prone hemochromatosis state. It looks like kind of garden variety type 1 HFE hemochromatosis. He has a little bit more in the way of organ issues, like with the abnormal liver size on ultrasound, than is typical for a type 1 patient in their 20s. But again, things like drinking and such may be contributing. His labs are consistent with iron overload. It is unlikely that the change in his ferritin from about 400 to about 1,000 over the course of a month represented an actual 2.5-fold increase in the amount of his iron. It is most likely that represented just some inflammation associated with drinking. He does have some evidence of pathologic iron deposition in terms of his abnormal liver function tests and the erectile dysfunction, but of course, as we talked about earlier, he has some other things that could be contributing to that also. One thing that is somewhat worrisome is that he has an increased amount of non-transferrin bound iron. Now, what do I mean by that, and how do I know it? The reason is that if you remember back, he was 83% saturated on his transferrin, but his 83% saturated, on his total iron binding capacity, but he was 116% saturated on his transferrin. Now, obviously, transferrin only carries two molecules of iron at a time. This doesn't mean that each transferrin molecule is now carrying 2.08 molecules. What it means is that there is iron there that is being carried by something other than transferrin. Now, why is that significant? It is significant because a higher level of non-transferrin bound iron is associated with with pathologic deposition in tissues like the liver, but particularly also like the heart. So patients with sickle cell anemia who have very high ferritins and who frequently have iron overload don't have an increased non-transferrin bound iron. So it's relatively unusual for straightforward sickle cell patients to have cardiac iron deposition. On the other hand, thalassemia patients who get the same number of transfusions are much more likely to have cardiac iron overload because they have a higher level of non-transferrin bound iron for reasons that aren't entirely clear. And that's a challenge. So what are we going to do with this patient? We started him on a program of phlebotomy. What about doing a liver biopsy? Back in the day, we used to have to do liver. Yes, sir.
So you said before you start treatment.
Yes.
If they're iron overloaded.
Yes.
And are we using the saturation versus
yes.
capacity?
Yes. Yeah. Either one. He's iron overloaded by either way. Iron overloaded would be an elevated ferritin plus anything greater than 50%. So he's overloaded either way. And he has some clinical. You would I would treat him with phlebotomy regardless of what, if he had these genetic mutations and he had those iron numbers, I would put him on phlebotomy at that point, because my goal would be to try and get him to not having any evidence of of organ involvement. The fact that he has some potential organ involvement makes this a little more concerning to me. That I need to. It makes me eager to lean on him a little harder about his phlebotomy. So back in the day, we used to diagnose hemochromatosis with liver biopsy. And what we would do is we wouldn't do it. We'd get somebody to biopsy his liver, and then you would measure the amount of iron in the biopsy expressed as amount of iron per gram of dry weight of liver. There was also a characteristic pattern of iron deposition in the liver. And so if you look at the liver, if you do an iron stain on a biopsy from the liver of a person with hemochromatosis, genetic hemochromatosis, as opposed to an iron stain on the biopsy of someone who's got iron overload from excessive transfusion, there actually is a subtle, but not that subtle, difference in the pattern of iron deposition. But mostly you did it on the basis of how much iron was present in the liver. So in many ways, you weren't really diagnosing hemochromatosis, you were diagnosing iron overload. Then with the genetics, we didn't need to do that anymore to make a diagnosis. Now, a number of folks like to get an assessment of the liver iron concentration anyway, and you can do that with a liver biopsy. Although what's become somewhat more trendy to do is, if you have the capacity to do it, is to do it with a T2 asterisk weighted MRI, which gives you a specific pattern for iron. And it's the standard, for example, for identifying cardiac iron overload by doing a cardiac MRI with one of these protocols. But the purpose of the liver biopsy nowadays is not to demonstrate that you have hemochromatosis or to demonstrate your liver iron concentration. It is to demonstrate whether or not you have cirrhosis. And what are the indications for doing a liver biopsy? Having hepatomegaly, having a ferritin greater than 1,000, or having an elevated AST. So those are indications where you think about doing a liver biopsy. And of course, my patient has all of them. There are some other ways of suspecting of getting at a diagnosis of cirrhosis that don't necessarily involve a liver biopsy. There is a test called a FibroScan, which essentially measures the elasticity of the liver, and it's less if you have fibrosis. And I've never actually ordered one, and the last time I looked into it, it wasn't actually, the closest place one is available is Asheville. So that's not immediately here. But you can estimate that. It's probably not quite as good as a biopsy, but it's pretty good in terms of demonstrating cirrhosis. There are also a number of formulas that you can plug in. The formulas are somewhat limited by the fact that initially you had to either have the amount of iron present from a biopsy, or you had to do a T2 weighted MRI in order to get an estimate of liver iron concentration. A paper that came out just this past week says that actually most of those formulas, if you just plug the serum ferritin in, will give you a better result. But in any event, so why would you want to know if you're going to have cirrhosis? Well, first place, it's not reversed by phlebotomy. And second, it gives you a 200-fold increase in the risk of hepatocellular carcinoma. In hemochromatosis, hepatocellular carcinoma occurs almost exclusively in people with cirrhosis. Again, the risk is not reduced by phlebotomy. So you can take a person who has this, they haven't done this obviously in a randomized way, but looking at sort of cohort studies. if you take a patient who has cirrhosis and you iron deplete them, take a population of patients and you iron deplete them, their risk of developing hepatocellular carcinoma is not different from that of cirrhotic patients who were never successfully iron depleted. So risk doesn't change. It's a cause of death in 20 to 30% of people with hemochromatosis. And so if you are at high risk for cirrhosis, or you have cirrhosis, you need screening against hepatocellular carcinoma. And the way you screen is with an ultrasound and with an alpha-fetoprotein every 6 months. So what am I going to do with this patient? Well, he does have some risk factors, but some of these risk factors may be exacerbated by alcohol. So, and when I did the ultrasound, there were no masses seen, and I checked an alpha-fetoprotein and it was normal. So there's nothing doing now, and so my approach is an approach of aggressive phlebotomy. I am encouraging alcohol cessation. Every 6 months, I'm going to be checking an ultrasound and an alpha-fetoprotein just to be sure. And later on down the line, particularly after we get patient iron repleted, we will likely be looking at a liver biopsy, or maybe by then there'll be a FibroScan in Johnson City. And I think that wraps up my last slide, and I'd be happy to take any questions you might have. Yes? I don't actually know. I would think it would, but I don't actually know. It would be a reasonable reason. It does not exclude the blood taken from them from being used for transfusion. But I think it probably would exclude you from being a liver transplant donor.
Does the neurological symptoms get resolved?
Do the neurologic symptoms resolve? So the answer is not always completely, but they may improve. One of the challenges is that depression resolves, but one of the challenges is that a lot of things that were described as hemochromatosis, particularly in the pre-genetic testing era, were not what we would now call hemochromatosis. So there's a whole bunch of iron overload disorders that are associated with heavy specific central nervous system deposition, and some of those got lumped in with hemochromatosis studies. But in general, other than depression, those are relatively low likelihood of response of neurologic issues.
So does the kinase mutation change the treatment?
The only reason it would change it would be if you had juvenile hemochromatosis, you are more aggressive in your phlebotomy. You'd be looking at trying to phlebotomize them every other week, twice a week, because you're trying to get as much off as you can, as fast as you can. That is the situation where where you're most at risk because the absorption is highest. Since the mutation appears to be a little at a point that interferes most, that is associated with the highest level of iron absorption. Okay. Any other questions? Yes, sir.
So did you say chelating agents are not?
They don't work. You can't get the iron off fast enough. Chelating agents, frankly, work best when you start them prophylactically. And so they work best in situations like transfusional iron overload, where you can predict with reasonable accuracy how many units of transfusion represent are going to represent a significant amount of iron overload, because iron overload in disorders for which you transfuse develops in the disorders where there is an underproduction anemia. So, if someone's GI bleeding, you can transfuse them till the cows come home, and they're never going to get iron overloaded because, of course, it's running out. It's myelodysplastic, thalassemic, sickle cell patients who just don't, who aren't making red cells effectively, and so that iron is still around. They're absorbing excessively because of the hepcidin abnormalities, and you're transfusing them too. So those are the folks where the chelating agents work best. Yes.
You said the target is for the ferritin to be below 50 or 40. Let me do.
Yeah, I generally shoot 450 for a level of 50.
Right. But there's certain things, like you said, non-transparent brown iron or something. So why don't we actually target the percent saturation?
Okay. The reason is that when it has been looked at, the ferritin is the better. Your issue is not the amount of iron circulating in the blood, it is the amount of iron that is deposited. And ferritin at that low level is the best predictor of iron deposition in tissue. So, you may say, well, from 400 to 50 is not that big a measure. Ferritin is a little less reliable at a moderately elevated level in terms of body iron stores with non-reticuloendothelial iron. But when ferritin is starting to get low into the normal range, then it actually is a very good indicator of total body iron. And the curve is, it's not a linear curve, it's kind of a sigmoid curve. So what'll happen is you'll have somebody with a ferritin of, 1,000, and you'll phlebotomize them for a year, and maybe their ferritin will get to 900, and then you'll, then 3 months later their ferritin will be 400, and then 3 months after that it'll be 50. So because again, it's not a linear loading curve. Other questions? Okie doke. Thank you very much.